So, welcome everybody here tonight. It's great that you could make it. I'm actually amazed to see that at the moment we've got 35 people on the webinar, and for a night like tonight in Victoria, well done. So, we've known since about 4 o'clock this afternoon that we're just heading into a 7-day snap lockdown after being out of one for 7 days. So, it's exciting times. So, Kirri, thank you so much for agreeing to come and spend some time with us to talk about this really, really important topic. Could you just tell us a little bit about yourself, where you studied, and just where you're working now, and where you worked just before you came here?
Can. Good evening, everybody. It's lovely to have you here, and especially to our Victorians. We feel you. So thank you very much for being here. So my name's Kirri. I am a dietitian and I specialise in paediatrics. I studied at Monash here in Victoria, and then after my studies, I decided that metro life was no longer for me, and I drove with no cares into the Queensland outback. And I found myself a job at the Aboriginal Medical Service in Mount Isa, which is near the Northern Territory border in outback Queensland. And that's where I started my life as a dietitian. And I used to FIFO to some of the most remote places in Australia, and I just loved every minute of it. And as a result of my work in the communities, I found my passion for pediatrics. I was trained at the Royal Children's here in Melbourne, and I'm one of the few dietitians that have specialist skills in pediatrics. And I really use those in the outback. And that's where I found the difficulties with disabilities and feeding. I looked after a lot of children with fetal alcohol syndrome, which display a lot of the similar characteristics of children with ASD. I also look after a lot of children with ADHD, and that's where I decided to get some extra training. And I was trained by the United States in sensory feeding and specialist approaches to feeding so that I could assist my children in the outback. Through that, it grew into an eating disorder knowledge, which has really excelled since the pandemic. So even though I specialize in children, present day, I obviously do not live in Queensland anymore. I'm back in sunny Victoria, enjoying lockdown for the millionth time. I work for Bobbi Cook as one of her fellow colleagues and as her dietitian for BCBM, where I specialize in disability feeding, pediatric feeding. And even though tonight we're going to talk about fussy eating and disordered eating, I do specialize in a range of pediatrics, including tube feeding, enteral feeding. We won't touch on it tonight, but cerebral palsy and the difficulties that arise with feeding. And although I love kids, I do also work with adults. I work for Ballarat-based hospital a couple of days a week, and I'm part of the transition program. So my role is to transition people off the ward and home. So I spend a lot of time in people's homes. When I'm not doing either of those, I operate my own private practice where I'm a specialist in gut health and all things IBS, IBD, and really helping people who struggle in that area. And when I'm not doing any of those things, I help look after some of the aged cares here in Ballarat and offer some assistance to some of our oldies that have really struggled during lockdown. So that's have I covered everything? Is that me in a
That's
nutshell,
great.
Bobbi?
No, I think that about covers it. Probably about the only thing that you didn't say is that we are looking to be setting up a eating disorder response here in Ballarat, and we're really, really excited about that. So having the psychotherapy and counselling alongside the dietitian in a really family friendly, trauma informed space. So I'm aware that we've got some parents online who have got children in Ballarat with eating disorders and really disordered eating. So Kirri is absolutely able to assist with that, and she's Medicare registered and also a registered NDIS service provider. So just want to let you know that there really is hope in Ballarat for some really productive and supported treatment and therapy in that space. So, Kirri, we kind of had a bit of a chat about what we would do tonight, and we talked about doing fancy PowerPoints and all of that sort of thing.
We did. And
But
then
the week
lockdown
has
came and that just went flying out
lockdown
the window.
came and it's been a crazy week. So, we thought we'd just kind of have a bit of a chat. So, a lot of our parents have got kids on the autism spectrum. I think if we did a poll, and I haven't got the poll button here, but I think if we did a poll, we would probably find that, 80% of our parents have got kids on the autism spectrum. So can you talk to us a little bit about what you often find with kids with autism and the challenges that they face in eating? And I'll just have my cup of tea.
Get comfortable. All right.
I'm going to.
Get comfy, everybody. So first of all, some of the initial referrals that I get are sometimes not even for children who have been diagnosed yet, because sometimes we don't get diagnosed until we're 2 or 3 years old. But I'll get referrals as early as 6 and 7 months. Fussy eating, the term is failure to thrive, and basically that means we're not growing appropriately. And quite early on, if you've got quite a trained dietitian like myself, I can pick up difficulties and issues a lot earlier than other people. And I definitely have started some NDIS plans for people whose children are definitely got some kind of neurodevelopmental delay. So if you're going to a good dietitian who's well trained, we can pick it up really early for simple referrals such as fussy eating. So the main referral I get is fussy eating, and that's what we're going to talk about here tonight. And before we start, I think one of the biggest things I get is actually from the parent, and it can be so hard when all your friends have got neurotypical children, and when they go through fussy eating, it's more about, I'm a 2-year-old and I'm going to pick a tantrum because that's what 2-year-olds do. And there are strategies, and quite simple strategies, that parents work through to overcome that. We overcome being 2 and we move on with life. So it can be really hard when you have a child diagnosed with ASD or sensory issues or other forms of atypical, that you have your friends around you with neurotypical children who are just saying, I'll just do that. I'll just make them. Oh, you just hide it in their food. They won't notice. And I can't see you all, but I'm sure you're all shaking your head going, they notice and they know, and I can't force feed my child. And so sometimes I find the first session with me is always with the parent. I don't usually have the kid in the first session. It's just you and me. And I usually find it's just a venting space, because for the first time, someone understands that their child won't eat. And no matter what I do, they're not going to, and they will starve themselves for a week.
Yes, thank you, Kirri.
They will. And all your friends are going, oh, it's easy. You just do this. And it's not easy. And so I just want everybody to relax and be reassured that I know, and I have seen it all, and I probably have seen what you're going through 100 times over, and that you are not alone, and that we are here as a community to support you, and that it is really hard for your friends who have got neurotypical children to get it, because they don't. So the strategies you've heard and the things you Google, where it's, oh, you just blend broccoli and add it to pasta and it will work. It doesn't. So switch them off. It doesn't work. And that's what we're going to talk about today. So I just want everyone to feel relaxed that you're not alone and you're not crazy. And so let's talk about the feeding. So there's so many things I could talk about with feeding, but I like to start with this. And that is that your child could not be eating for many reasons, but ultimately they want to eat. They don't not want to eat. We need food to live. And as basic human organisms, we need food. So your child is not doing it out of spite or because they want to. They are genuinely struggling. And that's a really important thing that sometimes we forget about. So there could be many reasons your child doesn't eat. It could be sensory. It could be tongue difficulties, it could be oral motor, there could be so many reasons. And that's why I work really closely with speech pathologists to rule out oral motor issues. And we work really closely with occupational therapists to rule out and assist with sensory issues. So if you've got an OT sensory profile, or you have a child and you're seeing an OT and would like a sensory profile, I highly recommend it, because it can help dietitians like myself structure the way we're going to assist you with feeding. So there are so many reasons that children don't eat, but ultimately eating is a learned process. It's not, we're not born and know how to eat. That's why we start with breast milk, and then we add some puree in, and then we add maybe a bit of crackers and whatever you did with your child as they progress through feeding. We are teaching our child how to eat. We are not naturally born knowing how to eat. And some people just need a bit more help when it comes to learning. So I want you to think of feeding and eating as learning. We are learning how to do it, and some people just need a bit more help. And then on top of that, one of the strongest biological responses we have as human beings is not to choke. So every single one of us, no matter where we're from, no matter what your age is, we have it ingrained in us not to choke, because we could die. It could go down the lungs, it could do all kinds of things. So choking is an absolute no-no for all human beings. So if you've got a child that is struggling with their tongue, they just can't use it very well, they need a bit of help, and they've almost choked on a food before and spat it out, the body's now learning that that food's scary. And there's a possibility that we could choke on it again, and we're not going to go near that food, because that is now something that could kill us. And I know that sounds crazy, and I know that sounds insane, but that is exactly what it is. The same way if you're scared of spiders, the same way if you're scared of snakes, if you go near it, it has the potential to do you harm. And that is what's happening with your child. Lots of children with autism report spitting out. They're constantly spitting out foods. They don't want to choke. It's automatic. Sometimes it is automatic. They put it in their mouth, it touches their tongue straight out. Some other children do something called pocketing, and they look like little hamsters, and they stuff it in their cheeks, because you've taught them that spitting out is not okay, but they don't want to swallow it because it's scaring them. So they've got to put it somewhere. And so in the cheeks we go. Sometimes children will also do that if they've got some tactile things in their mouth too. So that's not the only reason we pocket, but it's one of the reasons, and they walk around like little hamsters and you can see it. So something else I try and teach parents is food is scary. So when you're trying to get them to eat dinner for the millionth time, to you, it's just food. You know how to put it in your mouth. You know how to chew it. You know how to swallow it. They have absolutely no idea how to do any of those things, and you are forcing them to do something that physically scares them, because they are concerned, they're going to gag, and they're going to choke. And so what we have to do is undo all that, and we can undo all of that, but that's where we need to start, that it's a learned fear response, the same way we would help you with your fear of spiders or your fear of heights. It's exactly the same that we do with food. So sometimes, usually, I can't see you guys, which is really hard by
I know, it's the weirdest thing.
Going, yeah. So I really hope some of you are going, yeah, that's exactly what my child does.
Yeah. So, Kirri, I can tell you on the chat that we've got people saying, yes, mine does that. And so it's like fight or flight.
Essentially.
I'm just thinking about what you're saying. And when we talk about behavior management for kids on the autism spectrum, we go, okay, it takes 21 days to change a behavior and 42 further days to consolidate a behavior change. And that is in a neurotypical person, right? So you're looking at about 63 days to actually consolidate a behavior change. That's for a neurotypical adult. We're looking at 3 to 6 times longer in a child with ASD.
Yep.
So when we're talking about dealing with choking trauma, which is what you're talking about, we're looking at least 6 months of working on one thing to see a shift.
Yep, absolutely. Yeah, and it does take time. It's not one session with a dietitian and you're done. It does take time, and usually weekly or fortnightly is good. And I just want you to know that there is help, and people like me are trained to help you through this. And something I forgot to mention, I said eating is difficult. There are multiple steps to eating. It's not just mouth, chew, swallow. It is, I can't remember because it's a Thursday. I think it's 32 steps to eating. And someone correct me if you're a dietitian on here. There's 32 steps to eating. And that's from sitting down, getting comfortable in your chair, picking up your fork, picking up your food, putting it in your mouth. You do so many steps in your mouth before you will finally decide that it's safe for a swallow. And sometimes our children don't even like being in the room with that food. So sometimes step one is be in room with food. And whether it's your child or you know of children who they see a food and they run out of that room because they're scared of it. And so sometimes step one is just being at peace with that food in your space. And then we move up to touching it, and then we continue.
And even before that, Kirri, it's lots of kids with ASD have transition issues anyway. So it's actually getting them to be able to transition from what they were doing before it was time to eat. So let's add another half a dozen steps to your 32.
Yeah, for sure. And that's just the fear response. I've just seen someone puts up sensory stuff. Absolutely. We've got to add sensory on top of that. We've got to add oral motors on top of that. And there is a way. So don't sit there going, oh my gosh, this is so overwhelming. And that's why you also need a dietitian and an occupational therapist and a speech pathologist, because we all need to work together to do this. And we are hard to find. So it's not about finding a pediatric speech. It's about finding a pediatric speech pathologist who is training in this area. Same as me, there are hundreds of dietitians that have got pediatrics training. And if your child was unwell and in hospital, you would have so many dietitians come to you, but not many of us are trained in this area. And that's why if you've been to dietitians before and you've struggled with them, they probably don't have the right training. And we'll talk to you at the end about how you find us, so don't worry. And we are there, and it is possible. And in terms of encouraging your child to eat, and I hate to say this because as a dietitian this goes against everything, but vegetables are the hardest. Stop now without help, because vegetables, especially if you've got a sensory child, they're all different colors, they all look different, and then heaven forbid you can cut them in so many ways, and then you can cook them in even more ways. And the way you cook your broccoli is different to the way I cook my broccoli, is different to the way your auntie cooks the broccoli, and it's all just a big disaster. So vegetables are the hardest thing to come in. So when we talk about desensitizing children to their fear response of food, please don't start with vegetables. And as a dietitian, I should be saying vegetables for everyone, but in reality, that's not how it is with our kids. And if you've got a child that really does struggle with oral motor, meat is going to be hard too, because we take a lot of chomping to get through meat. So do start with pasta, rice. All children love fruit. Pick a fruit, any fruit, and we can go down these roads. And there's so much more I could talk on this topic. And if you are, and I imagine you're struggling, please find yourself a good dietitian who knows what they're doing, and a good pediatric speech pathologist who knows what they're doing, and we can start the journeys.
Awesome, Kirri. That's great. Look, our chooks at the clinic are loving having Kirri. I came out of my office the other day, and Kirri and one of our, 19-year-old classically autistic young friends, he was at the table, and Kirri so wisely started with food that he actually really likes. So they were trying to make pretzel faces and cracker faces. So food that he likes, crunchy food he's familiar with, nice and brown, so not too threatening. And he was circling the table. And that was all he could manage. But the chooks were happy.
Yeah,
the chooks are loving it. So it's just really taking that time and starting where it's tolerable for our young people and children.
And sometimes engaging with food is not eating it. So with the chooks, we fed the chooks. You want them to eat pretzels? We'll get them to feed the chickens the pretzels. And I crack out paint and we paint with potatoes like you used to stamp in prep, but you need to take the fear response away from food and make it fun, because right now they fear it. And so that's just one of the many ways we can just start making it safe for them again. And so, yeah, your chickens and guinea pigs get well fed, because your child may not be up for eating watermelon, but if they can pick that watermelon up and feed it to a guinea pig, that is huge steps. And that's what he did that day. And that was a really great day.
Yeah, and our guinea pigs and our chooks in the backyard are more than happy to help out there.
Love. Yeah. And so sometimes I've just seen someone put up, yours can't touch melons, but they may get so much excitement from you feeding the melon to a chook and them engaging and being in that space and changing the melon so it's not scary and wet and weird. It's now fun chicken food, and getting them to engage in that fun way.
Yeah.
I don't know if there are any questions, Karen, that need to be answered.
We've just got lots and lots of comments. Yeah, lots and lots of comments about people's experiences and their kids' experiences with food, and the smell and the texture and the taste, and even using knives and forks. And there's just another comment, even the sight of food, he'll decide within seconds.
Whether that's going to be something we do today. Yeah, for sure.
Yeah. And a lovely, I think it's your Heather, Bobbi, is saying that her son, who's now 18 in October, it's been hard to feed him and always constipated. So there's kind of one effects, isn't there, from not eating?
And about teenagers are teenagers. So not only do you have children who have ASD who already have fussy eating habits, as we become teenagers, they're growing into their own. They're learning that they don't need to eat fruit because they don't want to eat fruit, because now I'm a teenager and I don't want to do that. So when we have adolescence, we have that extra layer of complexity because they're entering adolescence. So if you do have an adolescence, I know how hard that can be, and it can be extremely challenging. And I just want to make a comment about the cutlery. Sorry, Karen. I'll quickly mention the cutlery. In our steps to feeding, cutlery can be really hard. So if you're struggling with feeding your child, let them use their fingers. Food is supposed to be messy. It's supposed to be dirty. So if the fork is not working, get rid of it. You don't need it. Put it down and just let them in with their hands. And if you want to encourage them to eat with their hands, do the same. Just get rid of the cutlery for yourself and just eat with your hands, and encourage your child that it's safe to use their hands. And I'll explain why. I really should have a fork here. Every time I show someone over Zoom, this is my fork, and I should really just have a fork. If you're trying to, if you've got poor motor skills and you're trying to maneuver a fork with food on the end and it's all a bit difficult, eventually you'll give up. But if you drop the fork and you're just holding something, if you've got oral motor issues, it's a lot easier to get this in your mouth and onto your teeth to chew it. So your hands are safer. So you're less likely to feel the need to choke if you've got your hands near your mouth. So if cutlery is not working for you, get rid of it. Get rid of it. Use your hands, and use your hands yourself, and encourage your child to use their hands.
That makes so much sense, Kirri.
I know.
Like, no, duh.
Yeah. And
really?
they gag on it and they stick it too far back. Yeah, just get rid of it. Say goodbye. Bye, fork.
Yeah. So just one question. How do you support, how do you support their nutritional needs while experimenting with food / scurvy, constipation, etc.?
Yeah, great question. If you've got a child that's under the age of 12, I highly recommend Paediatric. And it can be challenging if your child doesn't like Paediatric, and I've also handled that. And that's usually a food I bring in first. And then there's a huge difference between the powder form and the ready to drink. And if you have NDIS, it can be paid for by the NDIS. So that's a really important thing. Constipation is extremely common amongst children with autism just because of their lack of food variety. And something I do recommend from the pharmacy is Movicol unflavored. And don't let the pharmacist talk you into chocolate being the best, because our children with autism don't like it. So don't let a pharmacist talk you into the fun flavors. There is a junior Movicol unflavored, and you can add it to whatever juice they drink, whatever cordial they drink, whatever drink they drink, and it will work within 8 hours, and it's perfectly safe for under 12s. And then over 12s, you can use Sustagen for adults for nutrition, and you can use Movicol adult for constipation. So under 12s, Pediasure, Movicol Junior, both available in pharmacies, and then over 12s, Sustagen for adults and Movicol for adults, also in your pharmacy. All can be paid for on the NDIS, should you have the NDIS.
That's great. We've just got another question and comment. So there's been a couple of comments actually that it can take their child up to 2 hours or more to eat a meal. It's got a question. Do ASD infants do well with baby-led weaning?
Baby-led weaning?
Baby-led weaning. Sorry, got that.
For sure. There is a lot of evidence to suggest that. The evidence is still coming out, but to my knowledge, yes. And there's a huge amount of evidence coming out about baby-led weaning. The difficulty can be with autism is, again, with the gag reflex. When you've got a baby on a bottle, they know it's safe. They're not going to gag on it. And when you progress to food, sometimes they can need a bit more encouragement. But technically the answer is yes.
Good. All right. We're about halfway, Kirri. Didn't that go quickly?
And, you know, someone just said as well, sorry to answer the previous question, setting up meal times. We could talk a whole hour about how you set up the table for meal times to reduce 2 hours. So if that's something we could do that in the future, Bobbi, if you want.
Yeah, sure. Do you want to
I could talk about that forever.
Okay. Give us your top 3 tips for setting up the table for mealtime, for successful meal times.
All right. Number 1, for the first 10 minutes at the table, do not talk about the food. Crazy. But I want you to ask how their day was, or talk to your partner, or talk to whoever. I just want the dinner table to be a safe, fun space. Because if the first thing you do when your child sits at the table is you need to eat that, or you need to eat that, you're just adding to the fear response. So for the first 10 minutes, even if they play with the food or they stare at it, if they don't touch it for 10 minutes, just let them sit in that space and you eat, you do your thing, talk about your day, talk about whatever, talk about lockdown, talk about anything you want. And then at the 10-minute mark, that's when we start encouraging, but not encouraging in a forceful way. If you've got something new on the plate, what does that smell like? What does it look like? If you've got young children, it doesn't work with older children, but what does it sound like? Because then they put their ear down to the plate, and older kids work that out and they don't do it. But if you've got little people, what are your sausages? What do they sound like? And you also eat it and say, wow, that feels good in my mouth, or that sounds crunchy, or that was soft. I want you to talk about the food in more positive ways. I hope this is making sense.
It is, yeah.
And hopefully that encourages them. The table is more of a safe space, because remember, we're scared, we've got anxiety. If you've ever had anxiety, you know that eating is not your top priority. So we really just need to make the table a safe space. Number 2, and this is an OT question. So if you have an OT, please talk to them about this. Being secure in your seat. You can't tell from here, I'm only 5'2". And when I was a child, I couldn't touch the floor on the chair. So if your child does this, or is up on their knees, or is halfway over there, they're not secure in their chair, because little people are little and they can't touch the ground. So if you're trying to eat something new, it's scary, you can't use your fork, it's all too much. And then at the same time, you're not secure in your chair, it's never going to work. So make the chair secure. So if that means dropping down to a baby-sized picnic table and chair, so be it. Or you can grab a box and stick a box under their feet, so they've got something to plant their feet on. Some children who've got low muscle tone need the armrests to hold them up.
Yeah. Luca had a tomato chair.
Yeah.
So it's like a molded base and a molded back, and you can absolutely get that under your low cost, low risk consumables with the NDIS out of your course support. And we can, if you don't know how to do that, let us know and we'll help you with that.
because your child needs to feel secure in their chair because you're about to ask them to do something scary. So secure chair before we do the scary thing.
And we've got a question.
Yes.
Yep, just got 2 questions. So first question, what about ASD kids on risperidone, which overstimulates their appetites, though with very limited food groups? And then the second question is, can you improve gut health with adolescent ASD who has bouts of constipation with natural things?
Yep. So the first, yes, you can always improve your gut health regardless of your age, regardless of anything. So the answer is yes, but the answer is longer than that. So you'll need to see a dietitian for that. And then about the risperidone, you will need to meet with a dietitian, because what we need to do, it's not about the lack of food, which is a problem. The problem is if children on risperidone who have that over appetite overeat a certain food, they're likely to food jag on it, and then we'll lose that food that they eat. So there's actually a bigger problem there, not just the food diversity. And you do need to see a pediatric dietitian to help with that, because we don't want to lose a food, especially if they only eat a few. Yeah.
Yep. Just a question, how do you get Movicol through NDIS?
Really good dietitian argue for you. Put it in a progress report. Yeah. So for Paediassure as well, you just need a progress report from someone who knows how to write one. Yeah. And we were talking about this earlier. Not everybody is good at writing progress reports. Like we've talked about this amongst us, and you really just have to know how to word it. The NDIS are very particular with what they do and don't accept.
Yeah. And look, that's a bit of a learning journey for every therapist who's learning how to write progress reports.
Absolutely.
There was another question.
Yeah, there is. What about ASD and dehydration due to lack of fluids?
Yeah, that's a big one. And I'm assuming that's because they won't drink water. So I'm really hoping that child enjoys sugar-free cordial, and that is a really good option. Alternatively, what we've been doing with some families is juice, which is usually the common drink of choice. We slowly start watering it down bit by bit, and we give you strategies in how to overcome the tantrums and all the other behaviors that come with that.
And that's why you need a multidisciplinary team.
For sure. I can't do this by myself either. But I need my therapist, and I need my speechies, and I need my OTs. This is a joint effort.
Yeah. They're just asking what strategies are more successful to help ASD children drink more water? Is it cup style, water bottle, others?
Depends on the child and depends on their oral motor function. Because if you've got a child with low oral motors, they prefer sippy cups and bottles. Again, it's that gag reflex, because the bottle feels secure in their mouth and they know exactly where the fluid's going. Whereas a cup, like there's a wider rim and the water can go more places. And some children prefer that. So there is no answer to that, but that is definitely a speech pathologist question.
Yeah.
I find a lot of kids who really struggle to drink is giving them really quite finely crushed ice can be really, really helpful and really soothing. And they can walk around on, the shaved ice. You can just get those ice shavers, and that can be really helpful as well.
Yeah.
Really, it's just about experimenting.
And no two children are the same. So I have a whole list of patients and I'm treating none of them the same. Everybody needs a different strategy. Everybody needs a different approach, because everybody's different.
Yeah. Someone made the comment you can get Movicol and Oslo Max on prescription.
Yes, you can.
It's very cheap.
Yeah, so if you can get it on prescription, that's through your GP, and they're able to do a special Medicare something.
Yeah. Sorry, another question. How do you assist a child with ASD, ADHD who craves sugar?
Oh, yeah. There's no easy answer for that. And for that, I also require my therapists to assist with the behavior that's behind seeking the sugar. And it's also about us determining, is it like a sugar addiction, or is it that the foods are easier for them to chew that have got sugar in them? Yeah, that is a difficult question. That's a really hard one. And someone's just said same question, but salt. Again, are they choosing those foods because they're the easiest to eat, and they don't want to have to deal with the difficult consequences of trying to eat vegetables? or is it more an addictive seeking behavior, which my beautiful therapists do?
And that's where you need to look at, like, is it the salt or is it the chip that they're eating, like the crunchy, crisp chip, and they're going, "Nung, nung, 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 nung," and that's more a sensory thing rather than the salt and the food thing.
I'm just aware, Bobbi, of the time, and we could talk about this topic.
Yes. Yeah, I can see one more question there from Emily.
Yeah.
Yeah, sorry, just one more question. How can you assist a child who constantly moves around when eating back and forth from dinner?
Yeah, you need to be secure. They're not secure in their chair. This and the waving of the feet. They're not sitting secure in their chair. So you need to get a box under their feet. And if they love to do the side to side thing, you need a chair with arms like this to hold.
And just quickly before we go on to disordered eating and eating disorders, can we, good on you, Aisha. So Tanya was just asking about pureed food. Is that easier for them sometimes?
Yep.
Yeah. And Aisha just reminded me that I had said about 3 tips. So we need one more tip.
What did I talked about being comfortable in your chair, 10 minutes, call it at 20 minutes. Don't sit at a table for 2 hours. What torture. No wonder they hate sitting at the table. 20 minutes, call it, we're done. And if they're hungry later, that's okay. They probably will be, but we're going to get back up at the table and we're going to do the same process all over again. And sit with them. Don't make it a naughty corner. Sit with them. You'd like more dinner? Let's do that together. But please don't sit at a table for 2 hours. That's torture for you. It's torture for the child. They don't want to be in the presence of a fearful food for 2 hours. Call it.
Awesome. Well done, Kirri. All right, now I know that we've got a couple of parents who are very, very, very concerned about their children and young people who have got disordered eating and eating disorders. Can you first of all, Kirri, for us, describe the difference between disordered eating and eating disorders, or is it the same thing?
Fine line. You can have disordered eating patterns and not yet be diagnosed with an eating disorder. So an eating disorder is a mental health disorder, and it sits within the DSM-5 diagnostics manuals for psychologists. So in order to qualify for one of the eating disorders, let's talk about anorexia nervosa just as an example, you have to hit all the dot points for anorexia nervosa. Now, just because you don't hit all those notes doesn't mean you're magically okay, but it means you could have a form of disordered eating which can manifest into an eating disorder, and it doesn't mean you shouldn't seek the same level of help.
So if you've got disordered eating, can you access dietitian help under Medicare?
Sure can.
Really?
Yeah. So we'll talk about Medicare, and then I'll go back to eating disorders.
All right.
If under Medicare, if you are a person on this continent, you qualify to see allied health professionals 5 times a year. Any allied health professionals, whether it be dietitian, physiotherapy, occupational therapist, speech pathologist. The issue is you only get 5 a year on Medicare. And what you need to do is you need to go to your GP, and he's going to write you a GP care plan to provide you access to those health professionals. Now, the problem is if you are not diagnosed with an eating disorder, you only get 5, which is not many in the world of eating disorders. Whereas if you are diagnosed with an eating disorder, you qualify for an eating disorder care plan. And that qualifies you for 20 visits with a dietitian and 40 visits with a mental health professional every year. So even though it can be really scary to go down the path of diagnosis, you get so much more help if you are diagnosed. So please speak to your GP. The ultimate answer for this is please speak to your GP eating disorders are a mental health condition and are treated as such.
Yep, that's a great clarification. Thank you.
And then I want to talk about just the definition of eating disorder, because I think people hear eating disorders and think anorexia nervosa. I think that's where everyone's brain goes. Anorexia nervosa is actually the least common eating disorder by population here in Australia. It is the most fatal. So anorexia nervosa is important. It has the highest fatality of any eating disorder and is very high in the list for psychiatric illnesses in terms of fatality. So it's very, very serious, but it's actually not the most common. And so I don't want you to think, oh, but my child eats, therefore they don't have an eating disorder, because that's not how it works. It's about their relationship with food. What is your relationship with food? Is it good or is it bad? And if you've got a bad relationship with food, that can manifest itself in many ways. You may binge, you may purge, and what I mean by that is vomit or use laxatives to excess. You may have a really low self-esteem and body image issues. You may starve yourself and eat cucumbers for a week and then binge out on KFC for a day. I have seen eating disorders manifest themselves in many ways. And just because somebody is eating doesn't mean they don't have an eating disorder. And I think people think, oh, but they're eating, they're fine. Not fine. And it's about their relationship with food and how is that relationship. And for many of our children on the autism spectrum, as I said, we've had a fear response since we were a child. They don't have a great relationship with food. So something I want to make really clear is if you have a child with autism who's struggling with feeding, they do not likely have an eating disorder yet. We are just dealing with some of the difficulties and developments that come with children on the spectrum. However, if left untreated, and for those of you who have got adults now, over 19, they may very well have developed an eating disorder as a result of their ASD or their ADHD. And it's not their fault, but it means they need more support than someone who's, say, 4 and just being diagnosed with ASD. And then eating disorders do not discriminate. They don't care how old you are. They don't care what gender you are. They don't care what color your skin is. Eating disorders can affect everyone all the time, any age. So sadly, we at BCBM look after some very small children with eating disorders as young as 3 and 4. And I've got adults all the way up to their 80s and 90s struggling. Men and women are affected equally. Eating disorders can happen at any age. So please don't think, oh, I'm a man, I don't get it, or I'm too old for that, or I'm too young for that. So eating disorders can happen at any time.
Wow.
It's pretty heavy. I'm sorry, guys. We just announced lock it down and now I'm bringing you the heavy news.
Look, and I think it's really an important thing to be talking about, Kirri, because I was talking to one of our lead paediatricians here in Ballarat a couple of months ago about what he felt the impact of the pandemic had been and what was the biggest issue he had seen emerge here in Ballarat. And he said to me that there'd been a 450% increase in children aged 6 to 18 presenting with eating disorders and disordered eating, and a 150% increase in children aged 6 to 18 being admitted to the base hospital here with eating disorders and disordered eating. And thanks, Cindy. Thanks for coming. And that has had a huge impact on the health services here in Ballarat, and that our actual dietetics available here in Ballarat is actually shrinking, not growing.
It is.
So it's a really big issue, and that's why we're working together. We're meeting with Ballarat Health Services, Ballarat Community Services, and Ballarat Paediatric Practice to actually divvy up the needs in Ballarat and work out who's going to address what.
Mm-hmm.
So who's going to do Medicare work, who's going to do disability work, who's going to do NDIS work, and we're going to work with the private practitioners to really have a holistic response moving forward.
And we do need one. And I'd like to acknowledge that eating disorders is a difficult space for dietitians and psychologists alike. And I say this to everybody, but as a dietitian, I was poorly trained in eating disorders at uni, and I went to a good university. And the same goes for psychologists. So dietitians are taught, don't worry about eating disorders, the psychologists will handle it. And then the psychologists are taught, don't worry about eating disorders, the dietitians will handle it. So neither of us are well trained. And eating disorders sit in this weird space between mental health and dietetics. It's this weird, grey, murky area that no one really knows how to navigate. No one really knows what to do. So no one's touching it. And we talked with Counsellors Victoria recently. I gave them a seminar and I just really encouraged them to dive in, because we all need to start doing our part. And so what we're doing with Bobbi Cook and with Ballarat Health Services, which is my other employer, is we are going to start coming together and really offering support to local dietitians so that we can start building up the community, because we're having a very, very serious side effect from this pandemic, and it does not look pretty on a ward level, let me tell you. And if we can prevent our children from entering the hospital, I think we may be doing some of the best we'll ever do.
Yeah. Karen.
Sorry, someone's just asking about, they've got to leave now, but they just want the information about how to find a dietitian that has the same training.
Yes. Shall I put that up now, Bobbi?
Sure, why don't you do that?
Before people go, all right, guys, I've told you so much stuff. Let me show you how you find a dietitian. I'm going to share my screen. This is Dietitians Australia. Welcome to Dietitians Australia. This is our hub. This is where all dietitians are registered. This is our mothership, if you will. dietitiansaustralia.org.au. This is the front page. Anyone can come on here. Now, I didn't explain at the start. Dietitians are known as APDs. We are Australian Practicing Dietitians. That is our license. That is my beautiful title. And so on our main page, if you press this button, find an APD, and hopefully my internet loads. And there is a search function. So you can search either by name. So you can search me, I'm on here. You can search by business. You can just search by state. So I know we've got a lot of people coming from other states. You don't have to use Victorian. You can use WAE. You can use anyone. Zoom is a thing now. So feel free to access a dietitian from anywhere in the country. So you can go by state. You can go by what facilities they offer. You can go by area of practice, and eating disorders is on here. Pediatrics is on here. And then you can now tick as well for registered providers with the NDIS if you'd like to use your NDIS package, registered Medicare. If you have DVA access, as I know some do, you can find us all on here. So you put in anything that you want and you hit search, and it will connect you with a dietitian in your area or not in your area. Feel free to leave the state open and do it via Zoom. So I'm in the state of Victoria, and at BCBM, we do look after people all over the state and all over the country. And if you're happy with Zoom, Zoom's a bit harder when we've got disability feeding, because I like to get very hands-on, but I can absolutely start you on your journey. Eating disorders is a bit easier to do via Zoom. So Dietitians Australia, find an APD, find them in your area. And if you're struggling, Bobbi, is our email there?
Yes, it's accessible and people can get it from the website, and they've all received an email from us already.
So if you are really struggling, please don't hesitate to reach out to us, especially if you have a child with eating disorder. I think we really need to prioritize that.
Yeah. So Kirri, you said before, not all dietitians have got a clue about disability.
Yeah.
How do I find on this search engine here somebody that's got even some of the knowledge that you've got?
Well, this is
how do I tell?
How do you tell? It should be on here.
Oh, disability.
And look, right below it, eating disorders, like I prepared earlier. So there they are, right there. Disability, eating disorders.
Yeah.
And we've talked about a lot of things tonight. And if you're thinking to yourself, oh, well, I struggle with something different. I mean, we've got celiac disease on here. Someone talked about gut health. We've got gastro on here. We've got all kinds of things. We've got pediatrics. So I would recommend hitting disability if you have a child with disability, because they're more likely to be well trained. But yes, you can hit these buttons here. And if you've got a child being tube fed as well. Yeah, so it's all here.
That's great. Thank you for that. Good. All right.
We've
got about 9 minutes left. I think sometimes families get really stressed when their kids won't eat. They get
Yeah.
really scared,
Yeah.
like
Yeah.
really, really scared. And when people get scared, it comes out angry.
Mhm.
And no worries, Elfida, see you later. Like they get really, really, really scared. And that anger comes out. And in my experience, it can sometimes be the dads who are used to being able to fix everything for their family, and they really want to fix things. What can we be saying to our family members to reassure them so they don't feel so anxious and they don't get so angry?
What a big question, Bobbi, for a Thursday evening at 9:15. I like to remind people you're not alone. I started this off by saying you're not alone, because I think the biggest thing is alienation. And right now we're about to enter lockdown. So no one's going to feel more alone than we are right now in the state of Victoria, and also in Sydney and in Brisbane.
Yeah, and
So
the hunt is
please,
just going into
please
lockdown.
remember you're not alone. We are here and we get it. Please try and surround yourself with people going through the same thing, because your friends who have got neurotypical children are not going through the same thing. And I think that can add to the depression and the anxiety that comes with this. So please find that are going through this so we can be a support for each other. It can be really hard, especially I think a really hard thing is when we start therapy, we do hit walls and sometimes we go backwards, particularly with eating disorders. Sometimes we spend more time going backwards than forwards. And I think it's just really providing support to the parents that it will be okay, that we will make sure we do everything in our power, that the child is looked after, and that we can only do what we can do, and that you as parents already do amazing things. And if you've hit your ceiling, that's okay. And that's where we come in. And sometimes I hit my ceiling as a dietitian and I say, right, we need more help. We need speech. We need OT. We need a therapist. And it's okay to have hit your wall. We're not trained in parenthood. It's not a class we got when we were at school. And then you've been thrown these extra curveballs. So take a breath and know that it's not their fault and it's not your fault. It's no one's fault, but it is a form of learning disability, I guess. And we just need to learn how to go forwards together. I guess, Bobbi, you probably know more answers than me on this. I really just try and be reassuring.
Yeah, fantastic. Look, sometimes I think we need to kind of come at it with the support of a dietitian and then come at it from a totally different direction.
Sure.
Okay. So one of the things that we have learned is that the development of interoception is a real issue. Okay. So if we think about our senses, we know we've got our 5 normal senses. You know, our taste, our smell, our hearing, our sight, and our touch. So they're our external senses. So they give us information from the outside. Then we have 3 internal senses. So we have our vestibular sense, which is our balance. We have our interoceptive sense, is, you know, up and down, where our body is in space and time. And then we have our interoceptive sense, and that is making sense of what's happening in our body. So that is, what's that feeling in my tummy? Am I hungry? Am I thirsty? Am I about to throw up? Do I need to do a wee? Do I need to do a poo? Am I anxious? Am I scared? Am I excited? So with low interoceptive awareness, often our children can't make sense of that. We see it when they're holding a pen or a pencil and learning to write. I want to get in the camera the right way, sorry. They hold it too tight and they press too tight and they decide they don't like writing and they become reluctant writers. And that's because they've got really low interoceptive awareness and they actually can't understand that holding a pen too tightly makes their hand and their arm hurt. And so they really don't pick up that pain. And when we've got kids on the autism spectrum or sensory processing disorders or ADHD because they always have sensory issues going on. We just don't talk about the sensory components of ADHD very much. So they actually don't understand that it's causing them pain. So therefore, they can't say they're in pain. Therefore, nothing can actually, they can't access any help to change their state of being. So often kids who have sensory issues don't actually understand that something is burning their mouth, doesn't feel comfortable in their mouth, is burning their esophagus, is causing them to gag. They actually don't have the interoceptive awareness to be able to communicate that. So I would really encourage you, if your child is really struggling with eating, work with Kirri or your dietitian, but alongside that, find an OT that understands interoception, or get on Kelly Marla's website and do the, she's got 2 amazing webinar series that you can do, that you can get funded by the NDIS or through Carer Gateway. And if you need a hand with either of those, will help you. And you can actually buy a program that you can implement yourself around how to develop interoceptive awareness. And that can be a really meaningful place to start now. And you can just start really simply with hands and just noticing, oh, gee, this pen's really smooth. Can you feel how that's smooth? And you were talking about that interoceptive awareness before, Kirri, where you were saying, oh,
what does it sound like?
This carrot's crunchy. Or this cracker's really snappy in my mouth. Oh, that's very interesting. Or, oh, that yogurt is a bit sharp on my tongue. I'm not sure if I like that sharp feeling in my tongue. Because what we're wanting to do is we're actually wanting to increase their emotional vocabulary and their senses vocabulary so they can explain what's happening for themselves, and we can support change.